Okay, let's dive into this with our roadmap. We'll start with anatomy and lymphatics, look at the clinical warning signs, funnel down into the triple assessment, cover radiological imaging, and finally finish up with biopsies and tissue diagnosis. Let's jump straight into step 1.
Section 1. Anatomy and lymphatics. Fundamentally, the breast is just a modified sweat gland. It's supported by some pretty vital surrounding structures, and some of those even extend all the way up into the armpit, which is known as the tail of Spence.
Now, we need to zoom in microscopically to what we call the functional unit of the breast. This is the TDLU, or terminal duct lobular unit. This little structure is absolutely crucial. Why? Because the TDLU is basically ground zero. It's where the vast majority of invasive breast cancers and conditions like DCIS actually start. This is in stark contrast to the surrounding stroma, the connective tissue, which is where benign, non-cancerous lumps like fibroadenomas tend to form. So, figuring out exactly where a lump originates tells us a whole lot about what it might actually be.
So, let's see how this ties into the lymphatic system. Roughly 90% of the breast's lymphatic fluid actually drains right into the axillary or armpit lymph nodes. When surgeons go in to operate, they map these nodes using a really critical landmark, the pectoralis minor muscle. Level 1 nodes sit lateral to that muscle. Level 2 nodes sit directly behind it, and this actually includes a specific set called Rotter's nodes, right between the chest muscles. And finally, level 3 nodes are located medial to the pectoralis minor. Understanding these 3 distinct levels, totally essential for accurate surgical staging.
Moving right along to Section 2, clinical warning signs. What actually happens visually on the outside of the body when a tumor starts pulling on all those internal structures we just talked about? And this brilliantly illustrates the mechanical effects of tumors. On the left, we've got dimpling. See, the breast is supported internally by these things called the suspensory ligaments of Cooper. If a cancer involves those ligaments, it literally pulls them inward, creating this visible dimple on the skin. Then on the right, we have nipple retraction. If a tumor involves the lactiferous ducts, those are the tubes that carry milk, it pulls the central portion inward, retracting the nipple. But, and this is a massive takeaway here, while both of these are very serious warning signs, neither dimpling nor retraction actually indicates that the skin itself has been invaded by cancer. They're just purely structural pulling effects.
However, there's a condition called peau d'orange, which literally translates to orange peel, and that changes the game entirely. This happens when tumor cells block the subdermal lymphatics. Those are the tiny lymph vessels sitting right under the skin. The skin gets thickened and pitted, looking exactly like an orange peel. It's the most conspicuous visual sign to look for on examination, and unlike dimpling, peau d'orange absolutely confirms true, actual skin involvement in the cancer.
Section 3, the Triple Assessment Framework. This right here is the standardized clinical protocol that successfully diagnoses 99% of all breast lumps.
Here are the 3 non-negotiable steps. Step 1, history and clinical exam. This is where doctors map the lump using a dial clock method. Like, okay, the lump is at the 1 o'clock position 4 centimeters from the nipple. Step 2 is radiological imaging. And step 3 is histopathology, which is your biopsy. Now, the absolute key here is the strict chronological order of these steps. You might be wondering, hey, why not just jump straight to the biopsy and get the answer? Well, inserting the needle first causes microscopic bleeding and hemorrhage around the lump. If you try to do the imaging after that, the bleeding can make a totally benign, harmless lump look highly aggressive and suspicious on the scan. So imaging must always happen before a biopsy.
Section 4, Radiological Imaging Modalities. Let's look at exactly how a patient's age and tissue density dictate which machine the doctors are going to use. So, for patients under 40, an ultrasound is always the first line of defense. Why? Well, younger breasts have really dense glandular tissue, and on an X-ray, glandular tissue looks completely solid white. But guess what else looks solid white on an X-ray? Tumors. So, doing a mammogram on a young patient is honestly like looking for a snowball in a blizzard. It's just not sensitive enough. But as patients age past 40, that glandular tissue is increasingly replaced by fat, which shows up as black on an X-ray. Against that dark, fatty background, a white tumor stands out super clearly. That makes the mammogram the vastly superior screening choice for anyone over 40.
When they actually perform that mammogram, they always take 2 specific angles. The CC, or craniocaudal view, compresses the tissue from above and below. That gets you a really high-resolution look at the breast tissue itself. But the MLO, or medial lateral oblique view, compresses from the sides at an angle. This MLO view is critically important. It visualizes so much more of the breast tissue, and crucially, it lets doctors see all the way up into the axilla, the armpit, to check for those swollen, rounded lymph nodes we mentioned earlier.
Now, what's really interesting about this slide is the BI-RAD score. That stands for Breast Imaging Reporting and Data Systems. Whether a scan is being read in Tokyo, New York, or London, this universal scoring system ensures every doctor is speaking the exact same language. A score of 0 means the scan is incomplete, like if you accidentally did a mammogram on a very dense 25-year-old breast. Scores 1 and 2? Totally clear. A score of 3 means probably benign and usually just needs a quick follow-up in 6 months. But any score of 4 or 5 triggers an immediate red flag. It is suspicious or highly suggestive of malignancy. That means it is time to move straight to a biopsy.
But right before we jump into biopsies, we gotta mention MRIs. An MRI isn't for everyone, for sure, but it is the absolute go-to for a few specific things. First off, investigating breast implants. If an implant ruptures inside its capsule, the MRI shows these distinct wavy lines called the Linguini sign. Second, figuring out if tumors are multifocal, meaning they're all in one quadrant, or multicentric, scattered across multiple quadrants. This is huge because multicentric lesions strictly rule out breast conservation surgery. MRIs are also hypersensitive for finding DCIS, and they are the premier screening tool for young high-risk patients, like someone in their 20s with a BRCA gene mutation.
Section 5. Biopsies and Tissue Diagnosis. Up to this point, imaging has only shown us shadows. Now we need the actual, definitive cellular evidence. And there are two main ways to extract that evidence. FAC, or fine needle aspiration cytology, uses a tiny needle to suck out loose cells. But because you're only getting a sort of soup of disconnected cells, there's a really high risk of false negatives if the needle just happens to miss the core of the tumor. That is exactly why the TrueCut, or core biopsy, is the undisputed investigation of choice. It uses a thicker, 16-gauge needle to extract a solid cylinder of intact tissue. Because the structural architecture of the tissue is preserved, pathologists can definitively tell if a cancer is simply in situ, like contained, or if it's actually become invasive. Plus, it lets them test the tissue for hormone receptors, which literally dictates the patient's entire treatment plan.
To perfectly wrap your head around how these biopsy mechanics work, keep this memorable little metaphor from our source material in mind. If I have the entire bar of chocolate, that is an excisional biopsy. If I just take a chunk, that is an incisional biopsy. So a TrueCut core needle biopsy, that's just taking a chunk. It's an incisional sample.
And making this distinction clears up a massive amount of clinical confusion. The TrueCut biopsy is our investigation of choice. It's highly feasible, you can do it right in a clinic, and it's highly diagnostic. The gold standard, on the other hand, is the excisional biopsy, surgically removing the entire mass. Now, an excisional biopsy yields 100% accurate diagnosis, but it's a fully invasive surgery. Think about it. If a surgeon skips the TrueCut and goes straight to cutting out a lump that turns out to be cancer, that patient is actually going to require a second surgery anyway to properly map out those axillary lymph nodes we talked about. So the TrueCut is always the smartest first step.